course.
So we have a really nice turnout, and you're all amazing. And while we're getting ready, if you could mute your phones so that you're not disturbing others. And when you want to speak, if you are used to Zoom, you can raise your hands. I'm going to try to make sure I can see as many of you as possible, and I'll be roaming the street. I have a very large screen. I see all your names, and then if you want to show your face, you could do that. But I will be sort of looking around to make sure I can get everybody's hand when you if you raise your hands. But it's really nice. I see all of our wonderful patients here. It's really great to know that you would take the time in the middle of the day to join us.
Too much.
We thought we'll give people 5 minutes in case they have challenges with technology, so that we'll get started then. Okay, Gina, do you want to get us started?
Yes, so good afternoon, everyone. Welcome to our first in a 4-part series of Coping with Cancer During the Coronavirus Pandemic series. Today we have 2 great speakers that are going to share with you information around breast cancer for the newly diagnosed and for survivors. So first I'm going to just read a little bit of the biography, and I'm Gina Curry. I'm the Director of the Office of Community Engagement and Cancer Health Equity. And I am doing this in partnership with Dr. Olopade and Dr. Rajagopal. So Dr. Olopade is an expert in cancer risk assessment and individualized treatment for the most aggressive forms of breast cancer. She has excelled at integrating research into patient care at the University of Chicago Medicine since 1987, with a focus on risk reduction, early detection, and prevention in high-risk populations. Dr. Olopade helped develop treatments for young women, including women of African ancestry, that are significantly more effective with less side effects. Okay. Someone started sharing their screen.
Okay. I can share mine there.
Oh, there you are.
All right. Someone started sharing their screen over mine and I couldn't see everything.
I don't know why I'm sharing my screen.
So I'll just continue here. Dr. Olopade is a recipient early in her career of a MacArthur Fellowship. She has been honored by the National Academy of Medicine, the American Academy of Arts and Sciences, and the American Philosophical Society. She currently serves on the board of Lyric Opera, the MacArthur Foundation, and 2 Chicago-based companies in healthcare, Cancer IQ and Tempest. We will also be hearing from Dr. Olopade+Rajagopal. She is a 3rd-year cancer genetics fellow at the University of Chicago, specializing in cancer genetics. She completed her MD at Columbia University's College of Physicians and Surgeons, and also completed an MPH focused on quantitative methods in genetic epidemiology at the Harvard School of Public Health. She completed her residency in internal medicine at the University of Pittsburgh prior to coming to the University of Chicago. An aspiring physician scientist, Dr. Rajagopal currently sees patients with breast cancer and hereditary cancer syndromes and is currently conducting research under Dr. Olopade. So We're going to now welcome our speaker to share her screen and begin the presentation. If you have any questions, please put them in the chat box.
Yeah.
We can just leave it up, and then we can, that way it's just there for people to see that there's something, and then we can just
Sheila,
start
hold on
talking.
1 second. Sheila,
Yeah.
hold on 1 second.
Yeah.
So I just looked around to see everyone that's sort of on there. Some of you have your beautiful faces on, and it's really wonderful to see all of you. So how did this idea come about? It came about because we were asked to do a webinar with another not-profit organization that was really looking to share information with their constituents. And then I said, oh, we should bring this home to our patients because it was really well received. We were not thinking about it. And many of you, we have missed seeing you because we're not, we had to close clinic, and you can see me, I mean.
Put yourself on mute. Yeah, there we go.
Sorry. I was saying that we did this webinar for another not-for-profit organization that really wanted to get information about what's going on. And then I was just saying that I just looked at all of you in your I don't know that you are in your home, with God that you are sheltering at home, because by being able to come on this call, it means that you're alive. And that's what is really nice, to be able to see you all and be able to interact with you on this webinar. As we've said, our clinic closed because our hospital has been, having to take care of patients who come in with COVID. And I know there's a lot on your mind. Anywhere you turn around, it's COVID, COVID, COVID. But as I said, our cancer patients have faced a lot more risk in their lives than the risk of COVID. But we got many of you through this, and many of you are survivors. And you're here because you are survivors. You have developed resilience as breast cancer survivors. So that's why we thought that we should begin to have this question and answer with our patients who have developed resilience. And here's another threat to you that you're hearing about everywhere. So Dr. Rajagopal, she's one of those at the front line. Those of us who are over 60, they retired us. I have not been in the clinic since March 9th, even before the governor made the rule that everyone shelter in place. And why? It's because as you get older, you are at risk. So that's why I cannot say anything about COVID, but I do know a lot about breast cancer. And I know that when you're a breast cancer survivor, there's a lot on your mind. So that's why Dr. Rajagopal has been at the forefront. They're the ones taking care of patients. She has a lot more knowledge about that than I do, because I said in my decade, we dealt with HIV/AIDS. We were at the front line saving patients from dying from HIV/AIDS. And now this is the pandemic of their time. And so I'm going to turn it over to Dr. Rajagopal. She'll give a short introduction about what is going on, what we know, and then we'll open it up for questions and answers. Does that sound okay?
That sounds great. I'm going to mute everyone first. I'm going to mute everybody's phone.
The lady, Dr. Raja, been there for years.
What? Sorry?
That's the lady. Oh, she's out in her 60s about it.
Okay, go ahead.
Okay. So I'm hoping, so thanks so much, Fumi, and thank you all so much for coming to this webinar. I hope that for all of our patients, some of whom I know, some of whom I don't know, that we can offer you a little bit of information as to what's going on and try to synthesize everything that's kind of been happening, which is all very rapid and it has been changing day to day for our populations. So as I was introduced, I'm one of the oncology fellows who currently works under Dr. Olopade, and I've seen some of you in the clinic as well. And I think what we're going to talk about through all of this is just how to balance the risks for all of you as best as we can, and how oncologists are trying to think about this through all of the pandemic and everything that's been happening. So I like to try to answer a couple of FAQs, and you know, obviously as an oncology fellow, I'm not an infectious disease doctor, but we do training in internal medicine. We do training in epidemiology. So I just wanted to go over a couple quick basic things that people usually like to try to ask. One is, where are we? For the purpose of going through data, I'm talking about Illinois and what's happening in Chicago more specifically. I think that applies to most of us. And it's been really, really difficult to get good data kind of in terms of numbers and tests and cases and what's going on. So I think one of the easiest ways to try to figure out what is even happening is through the number of deaths from COVID. Even though the cases and testing and all that is getting better through the US and through Illinois. But what this is showing you is just that the curve really is flattening. The social distancing that everyone has had to do, all of this coming from home, it is working. And the rate at which people are dying, people are suffering from this, it is flattening. That's good news. So the FAQ update is what I like to call it. When can we get back to normal? So we're taking baby steps, and I think Illinois is doing a good job in at least describing what they're hoping to achieve, and Chicago as well. So at least here in the hospital, we've started to reopen some services, which I think is a relief to a lot of our patients. So mammograms, some surgeries, things of that nature are starting to come back online. In the state, J.B. Pritzker had announced sort of a 5-part reopening strategy for Illinois, and those of you who may be following along with him may be aware that we're in phase 2, the flattening phase, and we're trying to go to phase 3, the recovery phase. What that means is that in the phase 2 standpoint, we can start to get in more healthcare procedures from a healthcare standpoint. The phase 3 part is where we start to see more normalcy, more parks can open, stores, things of that nature. But where we can get there and when we can start to see that is really going to depend a lot on the hospital availability, testing, cases, etc. As things ramp up. The goal is just to be able to tolerate a number of people who are infected with COVID at the same time that everything else is happening, and making sure that we can give safe care to all of our patients at the same time. So people ask, what's going on with vaccines? What's going on with treatments? I've heard this, I've heard that. A lot of people talk about a lot of stuff with COVID. In terms of vaccines, just to give the quick update, there was a lot of hype on Monday. The earliest data of an early phase trial was reported, but we have no idea yet what that means in terms of how well it'll work to actually protect or help people. So this is still very, very early. And the timeline for a vaccine, if it were to exist, is still on the order of 1 to 2 years at least. In terms of what's going on with treatments to help people who are in the hospital for coronavirus, there are at least 10 medications that are on trials that are being repurposed from other diseases, none of which have enough trial data, including hydroxychloroquine, none of which have enough trial data that we can say we can be confident that they would do anything to help patients yet. This is all still very, very active, but this is at least as of this morning. But I think one of the nice things that I've started to see since we first started talking about this a couple of weeks ago is that I think the news media has gotten a little bit more of an understanding how much this is challenging for our patients, how much this is challenging for all of you. There were a couple of nice stories that I saw in the New York Times, at the Atlantic, that I just put up here in case you were interested in taking a look, of just patients describing their experiences and what it's like to go through treatment, what it's been like going to the hospital. etc. Your experience matters, and telling that story matters. And so it's been nice to see that there is at least more of an understanding of the unique situation that cancer patients are in right now. So what's the data for our patient population so far? Actually, this just got updated, I'd say, within the last couple of weeks at the AACR meeting. The largest studies previously had about 18 patients. Now we have studies on the order of 100 to 200 patients. In general, the idea is the same. The reason we're worried about risk is because patients who have active cancer are more likely to experience bad outcomes that we can tell. And bad outcomes here means going to the ICU, going on a ventilator, or dying from the virus. So far, there hasn't been anything that was breast cancer specific. They kind of looked at all cancer patients within the cohort that they could get across these studies. But the most common cancers that had COVID-19 infections and were in the hospital were blood cancers, lung cancers, and patients who had metastatic disease or stage 4 disease. And this higher risk for bad outcomes seemed a little bit worse if you had very recently gotten chemotherapy or surgery. There's very early data that people who are getting immunotherapy may not be as at risk of worsening severity, but that's in lung cancer patients. And so while these studies have seen patients who had cancer and seem to be asymptomatic, most of patients experience fevers, coughs, sore throats, difficulty breathing, the flu-like symptoms, but significantly so that they presented to the hospital. The European Society of Medical Oncology is one of several groups that I'll mention that has started to list at-risk categories of patients. And so the people who are thought to be at risk, who have cancer, are those who have received chemotherapy within the last 3 months, which is being pretty conservative. People who have undergone a lot of radiotherapy, people who are undergoing bone marrow or stem cell transplants, people who have certain types of blood cancers where your immune system can be suppressed, or people who have low white blood cell counts, which a lot of our breast cancer patients do experience on their treatments, or who are on long-term steroids, not just for a couple of days, for example, for nausea, but sort of ongoing steroid therapy or ongoing immunosuppression of other types. When we talk about who's at risk otherwise, it seems like these general comorbidity categories are pretty persistent throughout all of the studies on COVID patients so far. People who are 65 and older, although the range from the most recent New York data that was published yesterday is around the age range of 50 to 75. People who've lived in nursing homes, care facilities, people with chronic lung disease, severe heart disease, kidney disease, diabetes, hypertension, people who have a BMI over 30, and smokers. Across all the studies that we've seen, these patients are the people who have any of these factors seem to be at risk for doing worse from COVID. And we've had a lot of cancer patients say, hey, I have, one of these symptoms plus cancer. What does that mean for me? And we just say it's, we think that may be a little bit of a double whammy in terms of risk for doing worse. But we can't say, if you have diabetes and hypertension, you'll do this much worse than somebody who just has diabetes. We don't know. But these are the things to just be aware of, that you may be a little bit higher risk than the general population. So things that we can share that may be helpful. So ESMO Group, the American Cancer Society, and Cancer.net, which is ASCO's website, have all published very specific recommendations for patients that all have a lot of detail that may be helpful right now. And oncologists are following multiple cancer societies as we can, and as well as the guidelines from our institution. And so the NCI is the National Cancer Institute is giving recommendations about conducting clinical trials. The College of Surgeons is giving recommendations about how to reorganize and reprioritize surgeries, including breast surgeries. NCCN, ASCO, all of these groups are giving recommendations about how to try to prioritize therapy for patients as best as we can through all of this. So right now, at least for those of our patients who are genetic carriers, may or may not be affected by cancer, what we're telling them is that telehealth visits, we can still facilitate genetic testing through that, and we try to switch those to telehealth as best as we can. In terms of pursuing your screening, as things start to open up more and more, as we expect in Illinois, we'll be able to sort of have a slow restart of screening. But for people who live in other places, that may be changing. And people may not be able to start their screening yet, but we hope that that type of screening may be able to start soon. So a deferral of 1 to 2 months shouldn't matter so much if people are asymptomatic and not having any symptoms or issues that they can identify. If you are having any symptoms, new problems, new issues, please let your doctor know, because those are the people who we should get in to see and make sure that there isn't something new we need to be treating. There are a lot of different things that you may hear from your different physicians during this time. And so I listed a few different things that are consistent across all of the guidelines, and what you may hear is specific to your doctor. Several of you have heard some of this in our clinics as well, but your visits may be switched if you're not on active treatment at the moment to telehealth visits, or part of your visit may be getting your therapy, part of your visit may be by video. We enforce staying home as much as we can. Surgeries, like I said, are kind of in flux in Illinois at the moment and are starting to come back up. So your surgery, you may have heard some delays about your surgery, that may be changing. We are pursuing different strategies for chemotherapy and radiotherapy and giving those. That's not arbitrary, that's based on known dosing strategies that could be expanded that we're trying to implement more aggressively. So that we can have people physically come in less often. Trial enrollments are still changing and are still sort of difficult to implement at the moment because they require people to come in so frequently, but that's very much still changing pretty dramatically right now. And the one thing that's pretty universal through all of this is your doctor may start to ask you, if things do get worse, what did you want to have done at the end of your life? Have you started to think about that? That's not to make things more scary or more anxiety provoking than they already are right now. It's a universal recommendation that's been given just because we don't know exactly when or where people might get exposed to this virus. There's a lot of uncertainty everywhere. And part of our job as physicians is to try to do our best to service the needs of our patients. And certainly honoring what our patients want is one of the most important needs that we could do. So you may hear this from your doctor, and one of the things I think is most important is to not get more anxious about it just because they're asking. One of the things I've been telling everyone and try to keep in mind is the basics do still work. Wash your hands, the 20-second rule, it counts. Keeping yourself exercising, keeping yourself eating as much of a well-balanced diet as you can, kind of keeping some structure through all of this. It helps your mental health, it helps the physical health, it helps keep you going okay while all of this chaos is going on. There's a lot about the flux of what's going on in America as things are reopening. For people who are more at risk, I'd say for right now, we would still advise continuing to take sheltering at home pretty seriously, and not being kind of one of those people who's jumping out there first thing to just go hug everybody that you meet as soon as restrictions are lifted. Still going outside for walks, still keeping in touch with family, friends, your community. That nobody wants to take that away. And part of our job is also to try to help you be able to maintain all those connections, even if you're doing so virtually right I just wanted to put this up very briefly. ESMO has put up some guidelines for breast cancer patients specifically that are nice to look at, I think, just to get a sense of when your doctor's telling you, you know, right now it's okay to defer your visit, right now it's okay to switch it to telehealth. Part of where they're getting that from for breast cancer specifically, this is just a nice, more detailed guideline that I think is a little bit easier for patients to follow as well as doctors. They have a list not only of outpatient visits, but also med-onc and chemo visits, radiation therapy visits, surg-onc visits. So I think that's also a good resource too to take a look at. And they just list kind of the priority of what your visits would be when we kind of really do want to see you in clinic, as opposed to try to switch your visit to a telehealth visit. And I can go through that in more detail, but I just think it's a good resource to take a look at. But in general, just be aware that all of your doctors are just trying to think in general about how to balance the risk of COVID and infection from COVID and your risks associated with that with the risk of progression from cancer, complications from your treatment, and how to keep giving you your treatment through this. And so charts like these have been developed to try to help doctors prioritize when to give treatment, when to have patients stay away from the clinic. And very much we're trying to follow these types of guidelines for each of our patients individually. Just to give some clarification about masks, which I've heard is still pretty helpful, so I'll give that, although I think it's been a little bit more clear these days. The N95 masks, the ones that kind of look like this little white one here, in general, we're using those for healthcare workers who are in the ICUs, who are seeing COVID patients regularly. Those are a bit tougher to find, they're still hard to find, and we're trying to reserve those for people who are seeing COVID patients daily. The surgical masks, the little blue ones, those are shown to be helpful to protect you from droplets from other people, and they help protect healthcare workers in lower risk settings. So we, right now, the oncology fellows are helping to take care of patients not who have COVID specifically, but who are in the hospital for chemotherapy or complications and have cancer. And so for these patients, we're wearing surgical masks to try to help sort of limit risks as much as we can. These are a little bit more widely available, and if you have higher risk, for example, like your white blood cell count is down from your chemotherapy, but you have to go outside for some reason, wearing the surgical masks is not unreasonable, and it's something to talk to your doctor about. But otherwise, the cloth masks, there's some data that some types of cloth can help protect you too, but most of the time you're protecting people from your germs when you wear a cloth mask. But if everyone wears a cloth mask, everyone's protected from other people's germs. So that's why you hear everyone trying to say, you know, please wear a cloth mask. I don't know that it helps if you add like a bunch of cloth masks at once or anything like that. Just wearing one, if you're out about walking around the community, will be around other people, and everyone else is wearing one around you, we hope that helps. We think it does. And nothing really replaces staying at home, washing your hands, keeping away 6 feet as much as you can. I just wanted to emphasize that for those of you who are interested in research consortia that have cropped up specifically to take a look at what's going on with cancer patients, and these have been founded by the major international consortia in the UK, in the United States, across solid tumors, across blood cancers. You know, everybody wants to try to help gather data and help our patients understand what to do as best as they can. And on cancer.net, there's more specific resources for any patients of ours who have been affected by COVID in terms of financial resources and other support services, in addition to the support services that we also offer at the University of Chicago. So that's a very brief overview about the up-to-date data and things that may be available. Okay, that's it.
So thank you for that great presentation. Now we can start the question and answers period. I see that There's already a question in the chat box, so I'll read it. It says, as people return to work, should we anticipate a longer stay at home and possibly to get formal letters from a doctor or for employers?
It is completely reasonable to get a letter from us or from your doctors saying that, you know, I have a disease that puts me at higher risk. I should not be in an environment where I'm likely to get more exposed, etc. Insofar as that letter helps you, we are absolutely happy to write it.
Are there any other questions? You can either type in the chat box, you can raise your hand. If you hover at the bottom, there's a function where you can raise your hand and then I can unmute you.
And part of this too is because people hear all kinds of stuff, and exactly what we want to do is address that stuff. I think you're muted, Fumi's muted.
I muted her. Okay.
Can you, yes, okay. I can see those of you who have a video, and if you want to raise your hands, if you want to type, I can organize it. There are a few things that I just really wanted to add to what Dr. Rajagopal has beautifully presented. So the good thing that's really happened is we expected the worst and we escaped having the same disaster that happened to our colleagues in Italy. Before this started, before we had the close of and asking everybody to stay, to shelter in place, I was talking to my colleagues in Milan. Milan is where Bonadonna Veronesi, the Italian oncology group, they had the best health system and they did the most important work in breast cancer. And as soon as we saw what was going on in Milan, because I was in Paris at the time, I was talking to her daily, and they went to shelter in place. And as I spoke to her on FaceTime, she said, Fumi, go and prepare in America. Do not do don't let this happen to you, what happened to us. We did not have PPE for 2 weeks. We didn't know what we were dealing with. And I'm just afraid my patients are all going to die. That's what an oncologist in Milan was. And then we all started sharing information with one another. If there's anything that has happened as part of this global pandemic, it is the solidarity, the collaboration, the sharing of knowledge that we have all learned to do. And as I was talking to her, she said, I'm talking to all my colleagues in Chicago, in New York, Memorial Sloan Kettering, Columbia, they're all calling me because they saw how we were struggling in Italy. And so the good news is that we now learn about collaboration, being part of a team and working together. And as a result of that, the folks in New York knew what to do better. And then we in Chicago learned from New York, and you could see the collaboration that began. And then even now we have what I call regional collaboration, right? We're never going to be the same ever again because we have learned that we can actually talk to our patients on Zoom. We can use technology. You can reach out to us. So while we have been afraid of what will happen to our patients, with all of our patients succumbing to COVID, we have to take a victory lap, because the victory lap we have to take is that not only do we have good governor who really helped us to get the PPE, to get everything we needed, we had hospital directors, we had everyone who said, you know what, we're going to do this together. We're in this together. So while Illinois has been on the forefront saying that we're now having more COVID, we actually are doing more testing than a lot of states, right? Because we live in a progressive state where we're all saying we're in it together. So for you to come out and be part of this webinar, it means that you're in it together with us because you're all in your community. When we started this, we started preparing that we have to tell all our friends, if it turns out that you need a ventilator and there's no ventilator and you have cancer, well, they're going to not take care of you. And we fought. We said, you know what? Our cancer patients are dear to us. Just tell us what we need to do. So that's why our oncology fellows are going in there to treat cancer, to treat COVID patients, because we know that we cannot close the hospital. We know we can, those of us who are senior, we can stay in the backyard and do video calls, but we have to make sure we don't leave the front line, because at some point, Italian doctors could just not take care of patients anymore. They had to go and hide to be able to survive, okay? So I'm really glad that we didn't lose any doctors, at least in our hospital. We tried our best to save every patient that walked through our door. And now what we're doing is we're taking testing into the community. We're asking everybody to take hold of their community, talk to your neighbors, share the information, you know, get that. If you have Zoom and you want to talk to us on Zoom, we will make appointments for you on Zoom, but it's safe to come back to the hospital if you need to come to the hospital, because that's my next round, is that we, for decades, told you early detection is important. Go for your visits, get your checkup. So now we're telling you it's okay to wait. We don't want to give you double speak. If you need to go to the emergency room now, there was a patient who called over on Saturday, and I said, go right to the emergency room, because we know we can take care of you safely, because oncology patients have emergencies, right? And not every emergency is COVID related. So we have to be open to business. Those patients who have missed their mammogram and their MRI, we're asking you, we've scrubbed everything up. We are, even our clinics now, we're making appointments so that you're not all waiting for us. I know we are going to be better doctors now, because we'll never make a patient wait anymore, right? Because we can really plan ahead. We're thinking about how we can use technology, artificial intelligence to look at who's moving where, and care is going to be even better than ever before. When we started talking about having to tell our patients, if you're going to be needing a respirator, you may be dying alone. That's when we were asked to talk to our patients about that. And I thought, no, we're not going to do that. We're going to fight for our cancer patients. So we have enough ventilators, we have enough beds, we have drugs. And just so that you understand what it means to be able to be part of an academic institutions like this, there's a drug, remdesivir, right? This was a drug that was going to be used for Ebola. And then it turned out that, you know, they didn't develop it for Ebola, but they had studied it in China. And immediately, Dr. Rattain is an oncologist, is one of the best experimental therapeutics doctor in the world. And he said, you know what? I want this clinical trial to come to the University of Chicago. He called Gilead and he brought the study to our hospital. There's another drug that we use that is blocks IL-6. He called Genentech and said, we want that and we want to study it for any patient that walks into our hospital. We need to be able to do clinical trials. And guess what? Because we had those clinical trials, a lot of our patients survived. Okay, that is also the experience that I have had practicing oncology here for the last 30 years, right? When Herceptin was first being diagnosed, it was first being brought to save patients with HER2 positive breast cancer. I had patients come from Northwest Indiana. They got access to this drug, and many of those patients survived because they came to our academic institution. So the story of COVID is also that story. Our ICU doctors, they started looking at how to ventilate patients in a way that would allow them not to actually ever be put on a respirator. Molecular engineers, they started fabricating a way to make sure that everything is sort of, the airflow in the ICU is contained. All of these things helped us in terms of the fight against COVID. So I just really want to thank you to let you know that because of research, we are able to have all these wonderful outcomes. But come back if you need to come back. Now, let me read some of the questions, or maybe Gina, you can start reading.
Well, Kalila has her hand up. So Kalila, did you still have a question? You have your hand up. Kalila?
Yeah.
Yes, I have a question.
Yes.
Go ahead.
My question is, I just recently had surgery, matter of fact, on the 13th. And my question was, now that I have the flow tubes, you know, I have to drain my tubes and everything. I'm like, what's the next process with me going to see the doctors? I know they had to, when they took out the tumors and everything, they said they had another test to see if I'm gonna need the radiation or chemo. So basically, I'm like, I don't understand what's the next process because I haven't spoken with my doctors. I just know that I have an appointment next week.
Yeah, so we don't want to take personal questions on this call, but what we wanted to say is that many of you, so there's a question about who is a breast cancer survivor and why does a breast cancer survivor or a cancer survivor have increased risk for COVID. The question is, some of you are currently in the midst of treatment and you have to come to the hospital. If you have to get out, if you have to take public transportation, if you open doors, the more you go out, the more the chances that you can get exposed. The more exposure you have, the more you can get COVID. That's why a lot of patients who are undergoing active treatment might have a higher risk of getting COVID. And if they get COVID, they may not have the immune system to fight COVID. But if your cancer was 10 years ago, right? People still call you a cancer survivor. Some of you wrote and you said you are taking estrogen receptor, your tumor was estrogen receptor positive and you are on hormonal therapy. Does that put you at increased risk? To the best of our knowledge, it doesn't put you at increased risk. However, if you're going out and you're doing everything just like anybody else, you can get COVID. If you get COVID, now that we have bought some time, we have a lot of the new drug, we have clinical trials, we will do everything to try to save you. But the best thing you can do for us now is to keep yourself safe by washing your hands and wearing a mask, because that's what we mean by cancer patients and the risk of COVID, especially because we don't know who's going to have a mild form of it or who's going to have a very serious form of it and would need ventilators. Now we have enough of everything. Hospital beds are there. We have drugs that we can use. We have clinical trials that have been very promising. So that's why we're opening up in Illinois, even though the number of people who are still testing positive is still quite significant.
I just wanted to add just a couple things that I think people are asking that just are a little bit more specific. With regard to the question about cancer survivors and people who've had cancer for a while but still are called higher risk, part of that is just taken from the very limited data that we have from patients in China and Italy who had a cancer diagnosis and were in the hospital and had a bad outcome from COVID, even though their diagnosis may have been from years ago. We don't know the association, we don't have enough data to tell, but it makes us sufficiently concerned to say, we want to make sure you're aware, even though you don't have the same risk as someone who is on active treatment.
Yeah, so I'm grouping some of the questions that have been, that are in the queue. So somebody asked, and the good news now that the hospital has is that we have a lot of tests. So we're not restricting the test anymore. Initially, there were not enough tests to test everybody. So we would ask symptoms and we will only test if we were really symptomatic. Now, any patient of ours that says, I want a test, you can drive through and we can get you a test. if you're coming in, or if any health professional says, I want a test because I just want to test myself, we have more testing done now. If before you come for any major surgery, it is the surgeons will not operate on you unless you get testing done, because we know that some patients were operated on and then it turns out both the doctor who operated and the patient had COVID. So that's to any high risk procedure, we're going to make sure that you both protect both the doctor and yourself. So in regards to whether if you are still coming in to have your drains done and all of that, anyone who's been in the hospital lately will know that before you even enter the hospital, we ask you to wash your hands, to use Purell, and then we ask you if you have symptoms before you even enter the hospital. So we're trying very hard. Somebody asked, should I get my mammogram and MRI someplace else? We've actually, as a result of this work, we've activated all our satellite sites. Some of our patients went to get their treatment at Orland Park, and as long as we're on the same system, we can get your mammogram and your MRI. What we just don't want you to do is to ever approach us out of fear, right? But talk to your doctor and let us accommodate you. But if you come here, you're going to be fine, because we're wiping, we have everything we need. Everybody, I just took off my mask everywhere we go. Even if I go to the bathroom, I have to wear this around the hospital. So that is sort of the new normal for us now. And because I'm taking this call from my office, I know those of us who have been at home, we're all feeling really tight. So I left home, I walked to work. There's no one here. They've been wiping every place, but we're still being careful to make sure we wear our masks.
I do want to say one other thing about the asymptomatic testing. So if you get a test at some point, for example, you came in for surgery or something else, and then you notice, I don't know, maybe a week later that you start to have symptoms, the test is more accurate if you are more symptomatic. So it's totally reasonable to pursue another test if you had a test at some point and then start to develop symptoms. We definitely want to be aware if you're noticing that that's the case.
Yeah. So yes, thank you. So the answer to that question is, because you tested negative once, doesn't mean that if you start having symptoms that you can't still have COVID. So you need to, right now the good news is that we have lots of tests, and anything you feel, anytime you feel you want to be tested, just show up. We will test you instead of staying at home, okay? Because we know that the earliest you come in, the better the drugs that we have. The remdesivir study that we're doing, we have a lot of supplies now. We give it for 5 days. The clinical trial that we did, it was 5 days versus 9 days. And a lot of the patients who showed up early, they were discharged before they could even get to the longer day. So 5 days we have if you show up early. There's this question of how about research? In fact, for all of you who are breast cancer survivors, we actually want to do a survey. We're going to send you more surveys just to check on you, to see how you're doing and to see what kinds of research we should be doing. But the first thing that we opened up is our clinical trials. We were just joking about wanting to publish a paper, and it looks like we can't even get our paper published because everyone wants to publish about COVID. But I can assure you, the NCI is putting a lot of money out for us to study how COVID affects cancer patients, so we can learn when another pandemic comes, because it's not about if it will come, it's when it comes, right? Lessons learned. The other thing is, we also know that they are allowing us to continue to do our work. So my lab, we didn't close down completely. The university only wanted us to do self-distance. So there are 4 of us who can come into the lab, and we have to rotate who's coming in on every day to look at our cells, to make sure that the work is going on. And then of course, as a lab director, I come in every day just to make sure that my freezer hasn't thawed because, you know, an alarm went off and all of that. So we're protecting our research because we know that is the most precious commodity that we have. And for any newly diagnosed patients, we want you to be able to access clinical trials. So we've opened up our clinical trials so you can come in.
We're starting to, yeah.
Yeah.
I wanted to answer the couple of questions that are coming up about antibodies, because this is a very, very dynamic space right now. There are a couple of tests, mostly on the research side and our biobanking side, that are trying to figure out the best way to gauge if patients have had COVID or not. But this hasn't been rolled out fully to the community yet, and it's still sort of being determined kind of on the sort of in the national level, what's the best way to figure out if people have had the virus and can be sort of considered completed or having had it. For right now, I'd say we don't have a specific test. There's not something you should specifically look for. We don't check off that you're immune. But we're hoping, that seems like it's more along the pipeline than other things so far.
Yeah, I think the question is, so if you think at some point, many people are coming, and in fact, we were teasing all our breast attendees, Dr. Hoffman, Dr. Nanda, and all the breast attendees at some point in January got all sick. And we're wondering whether they all had COVID or they really actually had the flu. We don't know. So everybody is saying, oh, you know, at some point I was sick. Did I have COVID or was it just the flu? In the winter, many people had the flu. We don't know whether it was COVID. If we test them with the antibody, does that mean that then they shouldn't worry about COVID? We just don't know, right? There's just so much that we don't know about this virus. And what we want to do is to really just make sure that our patients are safe and that you are safe, and that if you have any questions, you can ask us. I don't see anyone else raising their hands.
I do want to give a quick shout out, just if you do have symptoms, you're worried you have symptoms, there's any question of that, Sarah Bezzetta, our fabulous PA, just to give a reminder that we do have both my chart. You can, there's like a specific thing that you can put in, hey, I think I have symptoms of corona, what should I do? And you get listed several options. We also have a phone hotline at 773-702-2800 that you can call. That'll list ways that you can pursue testing and kind of what to do next. We have a special clinic that patients go to if they are concerned that they have symptoms, and can pursue testing for that, as well as a drive-by clinic or drive-by testing.
Yeah, there was a question about how much radiation is too much radiation. So remember that the virus really does a damage to your lungs because it can replicate in the lungs. And if you, for example, had lung cancer and then you got radiated, or you had a blood cancer, a lymphoma, and you got radiated, if there was already some damage to the lung, even people who have asthma, right, or smokers, those are going to be the ones who are going to have a harder time fighting COVID, because the problem is you just can't breathe. So if your lung is already compromised, right, then it's harder for you. But you know, one of our senators has only one lung. He tested positive for COVID, but he didn't have any serious problem because he had a mild COVID and he was able to function with just one lung, right? So the key thing really now, I'm feeling really confident about COVID in the sense that we know a little bit more about it. We know some things that work, you know. Johnson, the Prime Minister of the UK, was a smoker, or, you know, 56-year-old man, and he said his healthcare provider saved his life. Why? Because he was a bad smoker who already had compromised lung, but they helped him to keep alive by helping him to breathe, and they never needed to intubate him. He probably also got access to some of these drugs that are now really, you know, showing up to be good. And guess what? He survived it. So that's what we mean by when you have too much radiation, or you have had damage to your heart, damage to your lungs. If your immune system is weakened, you just don't have the ability to fight. And that's why we try to say prevention. This is where I'm now going to make a pitch about prevention. prevention is better than cure. We want you to stay safe so that we don't have to treat you for COVID, right? We already have a really wonderful relationship with you as our breast cancer survivors. We want it to be just that, right? And for those of you, I know many of you will have friends, or you may know somebody that you have lost to COVID. It's a sad moment in our history, and we all need to figure out how to develop resilience. We all need to be able to go out, enjoy the sun, enjoy the roses, eat lots of fruits and vegetables. Every day we're alive is a new day, and this pandemic will come to an end, and we will continue the fight to find new cures for breast cancer. So until then, you guys just need to figure out how to thrive as survivors. That's what we have, unless somebody else has more questions that they want to ask us.
There's one last question about building up your immune system, and I think it dovetails very nicely to what you just said. There's not a magic bullet. Try to exercise, try to sleep well, try to eat as best as you can on not a specific diet, but just fruits, veggies, balanced diet. Keeping yourself healthy is the best that we can recommend during this time, and that'll do you a world of good either way.
All right.
So
And
let's thank both of our doctors today for a great presentation. It's 2 o'clock. Did you have any closing words, Dr. Olopade? I saw your finger up.
no, I just wanted to really thank everyone who showed up on this.
Thank
and
you
I want
so
to thank
much.
the Cancer Center, because I also saw that the director of our Cancer Center, Dr. Lebeau, is there. I know that a lot of women in the women's board who support our Cancer Center, who donate to our Cancer Center, they showed up. And all of you support us one way or the other, because you participate in research, you gave us your tissue to study, and without you, we are not the academic center that we are. And so just really want to thank all of you again for showing up, and we hope you stay engaged and you continue to be part of our community. Thank you very much.
If you have a second, please fill out the session evaluation in the chat box. We're going to stay open a few more minutes. It literally takes 60 seconds or less. I see a question about the video. Yes, when the video is ready, we'll have it where we can send it out if you want it. If you want to put your email there, we can make sure you can watch it, and we can possibly post it somewhere. I'll have to check with that. But I did record this and it can be viewed later.
Participants are dropping off.
Yeah. So while people are filling out the forms, there's somebody has raised a question about whether we will continue this community. We can continue anything, because you can ask us and we will make it happen. And if there's interest in forming a community that, you know, periodically wants to get together as breast cancer survivors, we're happy to keep that going. But I have to hop on to my next Zoom call. But thank you all for everything.
Thank you.
And
Next
I just
is
want
on Wednesday.
Okay.
I just was going to say that if there are any questions that we didn't address, I know a couple of ones have popped up about specific parts of your treatment. Ask your doctors if you are worried that that answer isn't clear or it still doesn't make sense. Part of this is for all of us, and I think all of our colleagues work together to try to figure out the best solutions to make sure all of our patients are comfortable. And we always want to make sure everyone's comfortable. So reach out to your doctor if something wasn't clear about either radiation or any therapies we didn't address, etc.
Thank you.
Radiation.
What could be improved for future sessions? Mhm. What other topics do you want? Webinars? I just put the clinical trials.
You know, like ongoing results they're having with the clinical trial.
Mhm.